I'll talk a bit about why a consultant geriatrician is talking to you about air filtration, because it's leagues away from what I do normally in my job. I normally prescribe antibiotics, although always at the advice of a microbiologist, I must add. I'll sort of, my penultimate slide, I'll sort of explain why I got into it. So I'm just going to talk briefly about why and how we commissioned our basically our intervention for the Addenbrooke's air disinfection study, and why it's not as easy as what you might hope. Air, obviously, if you've probably heard from some of the previous speakers, I think it's the next big problem that we have to deal with. We've sort of done waterborne, we've done foodborne, and airborne, as the COVID pandemic has shown us, we don't really do that well, particularly in hospitals. I'm just going to sort of talk through why that's an issue. I'm going to sort of highlight English data mostly as why that's an issue. Some very, very basic, some ventilation. I know you've had a lot on ventilation, so this is how much I understand of ventilation. And then the big bulk of the talk is going to be on commissioning the air filtration units for our study. So SARS-CoV-2 and the NHS. So it's obviously, you all know, it's now predominantly thought to be an airborne virus. Sort of experience has taught us that. I've never done contact precautions as well as I've done at the start of the COVID pandemic, to the point of, I think I lost 2 stethoscopes because I was always taking it off, cleaning it, putting on a little square that had been pre-cleaned, sort of peeling off the gloves, a hand gel after each step, to the point that my skin was peeling off. So we are never, ever going to do contact precautions and droplet precautions like we did in the NHS back in the first wave. But did it make a difference? I'll show you data to show that actually we probably were going barking up the wrong tree. Up to 1 in 4 hospital-acquired cases of COVID are actually acquired in the hospital. So of all the patients that are in hospital with COVID at any one time, the worst we've ever done is 25% of those patients actually catching it there. Now, those people are already very sick. They're in for hip operations or heart disease or strokes, and then they get COVID. And what we know is that although whatever the reason COVID is becoming less of an issue for some people is because of vaccination. The difference between Omicron and the wild type, there's no difference if you're unvaccinated. And what we've seen and what I've seen as a clinician is every single health outcome is worse if you get COVID, even with Omicron. So that's a big problem. The other big problem, and you've heard that from our speaker from NHS Innovation and Improvement, is that 55% of hospitals do not meet current HTM. Now, they're not legally required to meet HTM 301, because it's not retroactive. So Addenbrooke's, where I work, I think it was built in the 70s, was built to a certain standard, and then obviously HTM03 came in the late 2000s. But we've had 15 years since that came in, and there hasn't really been much improvement or significant improvement sort of countrywide. So we've got a big problem to deal with, so hopefully we'll start to get on to how we deal with it. So I put this slide up. This slide is a little bit controversial because I don't want to sort of name and shame, but this is just the variability that we see. So this is English NHS Trust, because you can't actually do this data with the publicly available data that Scotland distribute. But these are all the NHS Trusts where we can be reasonably confident about making a proportion about how much of their hospital acquired COVID. So you have some trusts where you were only getting around sort of 1 in 10. Unfortunately, you get other trusts where it's up to almost 1 in 2, so up to 40% of their hospital-acquired COVID. This is up to 2 weeks ago, the previous 90 days, so it's still a problem. You can see that not only do we get variability per the trust, but you also get variability over time. So this doesn't exactly fit the UK pandemic curve. What we've seen in hospitals is that you reach a tipping point whereby your cohorting is overwhelmed, you run out of side rooms, your testing all of a sudden is taking sort of 24 hours longer, and then you don't know what COVID you've got, so then it spills over into your wards. And once you've got patients with undiagnosed COVID in your patient bays, multi-occupancy bays, then it becomes more of an issue. And you can actually see, so this is the Omicron wave. we've not done as well in the Omicron wave as we did in the Delta wave, despite having sort of more patients. Now, I don't quite understand, hopefully some people will know that it's either we're pumping out more virus or the virus is more infectious. But whatever the case, we've got a bigger problem now, and the virus is evolving. It's evolving quicker than what we can sort of adjust to. And so the next wave, Omega, I don't know, whatever they're going to call it, may be even worse than this. And the real bad outcome would be that not only does it evade sort of immunity and is more infectious, that it's actually more severe and causes more of the original sort of disease that we're seeing with wild type and with Delta. Oh, sorry, just go back. So does anyone want to hazard a guess at what the arrows are? So you'll see all these little arrows up along the side. So I also sort of do sort of patient and staff safety with a group called Fresh Air NHS. And a lot of people have anonymously told us whether their trusts are using airborne mitigations. Now, this might be just simply using FFP3 beyond AGPs, but in some trusts it actually means HEPA wherever you look. It means FFP3 for anyone that's suspected of having COVID. And all the arrows are those trusts that are doing that. And I hope you sort of appreciate that it sort of clusters down the bottom for those that are, so down is good. So these are the lower rates of hospital-acquired COVID. So at Addenbrooke's, it's really difficult when you've got something that's so infectious and you end up having a third of your ward patients with COVID, because you don't know actually who's given it to who. And if you believe in sort of droplets, what you will say is if a patient is in Bay 1 and then another patient is in Bay 2 and another patient's in Bay 3 that's all got infection, then what goes from 1 to 2 to 3, it's the staff. So then you sort of attribute it to an infected staff member and you just say, well, that was the route. But what we did in Addenbrooke's is we actually just took all the human out of it and looked at the genetics of the virus. So we took all of those samples from patients, from staff. We looked at the genetics to say, actually, if it's so closely matched from one to the other, then it must have passed from patient A to patient B. Patients in this diagram on the left-hand side are in white. Grey are in grey are the healthcare workers. So Addenbrooke's, just for a bit of background, since May 2020, we had the first UK asymptomatic PCR screening programme. We're very lucky in that just south of the city, we have the Sanger Institute, so they could do all our genomics. But essentially, Chris Illingworth is he now actually works in Glasgow, you've pinched him. He basically modelled who infects who, and you can see that actually the outbreaks are huge. And he basically showed that super spreaders are driving hospital-acquired COVID, which we now know is a hallmark feature of an airborne pathogen. And then down on the bottom right, so who infects staff? So it's about 50-50. You're probably equally as likely to be infected by a staff member as a patient, but still a lot of staff are getting infected by infected patients. And then if you're a patient, you're 9 times out of 10 going to be infected by another patient, because you're spending most of your time with them. So, big question, do airborne controls work? So those arrows that I showed you previously, so this was done in the Alpha and Delta wave. So I think we had 16 trusts in England that we knew at the time that were implementing airborne controls. Now this is usually just FFP3 respirators beyond AGPs, but what that means is that other things will follow. So if you believe that the virus is transmitted through aerosols such that you're going to tell your staff to wear a respirator, you're probably also going to test the whole ward if you have an outbreak and not just the bay. Similarly, you're probably also going to be looking at your ventilation and also HEPA. So it's a good surrogate marker for are they doing other things with regards to the air. And we saw in the alpha wave, we had a 20% reduction in those trusts that were using airborne mitigations. And actually that increased as what we think is probably testing was easier for both staff and patients. So if you remember back to the first wave, it was not uncommon for it to take 72 hours for you to get your PHE approved COVID swab, which is a nightmare because you're putting suspected red next to definite red. And then if you end up not having COVID, you've definitely got it by the end of the 72 hours. So we actually went to 33% reduction in the Delta wave. I'd really love to run this back in with the Omicron wave because we're all really good at testing now. We've now doubled the number of trusts that we know of that are using airborne mitigation, so up to 36 at the last count. So watch this space. This was published in the Journal of Hospital Infection. I think it was out in paper copy in February. So my take on ventilation, and it's you'll be glad to know it's just one slide. So this is what I take for ventilation. So green is what already exists, so that's number one. Number two is what we're putting in the Addenbrooke's Air Disinfection study. I've just sort of said it's filtration. Actually, the units have UVC bulbs on the filter. Now, that was a prerequisite from Addenbrooke's that we disinfect the filter such that when we change the filters, there's not a risk of those things going back into the environment and potentially causing a problem. So two and that unit there is sort of combined 2 and 3. Actually, I think the future is probably 3. You've heard a bit, I think, from Frank earlier about how UV is going to be there's going to be a standard set up for healthcare settings. Far UV is probably the way things are going to go. And Kath Noakes, I was listening to a talk from her that you can get up to 10,000 equivalent air changes. Obviously, it's not air changes, but because it's disinfecting all the time in the entire space, and hopefully safe for human habitation, that you can get up to massive air changes. And actually, 3 may well deal with this. So it may well deal with the short range. So all of 2 and 3, if you're talking about upper room UV, it's always just talking about far field or medium to far field. You still need protective equipment for close range, obviously. So that's my basics over. So commissioning the Addenbrooke's Air Disinfection study. So commissioning, why do it? So it's for exactly the same reason that HSE say that if you're going to wear a respirator, it has to be fit tested. There's no point putting in a machine, going to a supplier and saying, can I have 50 HEPA filters? Where do you put them? Well, you're limited to where you put them, basically for where your sockets are. If you're anything like Addenbrooke's, there are no sockets. So you're basically having to put the intervention where your sockets are. Otherwise, you're going to have cables everywhere. The other reason, I think, for commissioning is that when you're talking about what sort of standards these things are having to be put through, actually there's no standards at the moment. Tony Fisher up in, I'm normally giving this talk in Cambridge. Tony Fisher down in Liverpool, who's working with the Chief Scientific Officer office, Chief Scientific Advisor's office. He's setting up a lab basically to put filters in clean rooms and then aerosolise some bacteria and then see how effective they are at cleaning. Does that apply to when sticking them in a hospital environment, which is full of people that are all mixing the air, that are all coughing, spluttering? I'm not entirely sure. And this is the sort of the environments that we sort of see. This was my ward on a nice tidy day, and sans people. But you can imagine putting people and staff into that mix. This ward actually is a geriatric ward, as I've already alluded to, and we often get sort of wandering patients that don't abide to isolation precautions that will be continue, even if infected, will be wandering out of their room. So we then put the HEPA filters in that environment. These are all pictures taken from Addenbrooke's in the last week. Do they work? Is that unit in the top that is a corner unit placed in a corridor having the desired effect? Is it cleaning in the bays? So our wards are, I don't know whether they're similar to yours, but we have 4 6-patient bays going on to a shared corridor, and then we have, I think, about 3 side rooms on most of our wards. So where you put the machine, is it actually cleaning next to the patient? Because that's the main problem that you're dealing with. It's not sort of, patients don't spend all their time in the corridor. So is it in the right place? Are the filters maintained? So we've obviously got a lot of these machines now deployed across Addenbrooke's of various different types of manufacturers. And we've sort of employed an individual to basically maintain all of them because it's a big job. These things are not in just for COVID. We're learning, actually, there's a lot more things that are transmitted through the air. And they're probably going to be for 10 years until HTM starts to apply retroactively. You've heard about the standards that are being set from conferences like this and the Royal Academy of Engineering. It will come, and it will also probably come that the CQC will start to look at hospitals and say, how well are you performing on those league tables? We do the same for MRSA and C. diff. How are you? Where is your trust? And if your trust is a similar bill to another trust, why is it that your rates are higher? I think I'm not generally an advocate of that type of approach, but I think we do need to have a big sort of incentive to drive improvement, because it's going to cost. These machines aren't cheap. The bottom unit and this unit are both part of the Addenbrooke's Air Disinfection study. You can actually just see, one of the key things we found is on the top they've got these little boxes. You can't see that one because I cut it off. But they're actually just Wi-Fi boxes, so you don't have to send a person to check whether the filter's healthy. You don't have to send a person to check whether it's on. The machine will tell you whether it's on. It will tell you whether someone's fiddled with it and put it up to clean room setting or whatever, and you can remotely just turn it down. So actually you're stopping people having to go and see these units unless you need to. It will tell you if the bulbs have blown or something like that. And 9 times out of 10 they're not switched on anyway. So this is another one of those boxes, but what we're using in the study is, you'll see most of the machines in on display, or the machines, the HEPA filters that you'll buy in say, Argos or whatever, they have auto function. So what they do is they have a little detector in them to tell you how clean the air is. The problem is that's next to the filter, and the filter will always clean the air immediately next to it. And so what will happen is it will ramp down and ramp up and ramp down depending on whether it's cleaning itself, which is useless. I mean, also the manufacturer will say our filters have extended life because they're turning down because they're cleaning themselves. It's bizarre. But what we're more interested in is if we put those sensors above the patient's bed, the machine then controls the air next to the patient's bed. So it will ramp up. So what we've had before is someone will turn off the machine that's in the corridor. The bay machine will detect that because the PMs will increase, and then that will ramp up. So the whole system modulates. It's also really good at night time because people don't move at night time, and so the particulates and obviously breathing rates go down, aerosol contamination goes down, so the machines can go down so that we're conforming to sound levels for sleep. So they not only detect particulates, they detect CO2. We haven't actually found that's very helpful because like this space, it's a big space, it's all mixing the CO2. So we haven't used the CO2 as a marker of risk. But the other things are important. So humidity, temperature, and air pressure, obviously, because we want to know where the air is meant to flow from one space to the other. And temperature, why is it that you get more line infections, bacteremias in the summer? So we're going to be looking at sort of different diseases over time and how we're modulating the environment. And the other important thing is for those of you that are in a state, is that not only do you not have to go onto the ward, you can see remotely what the ward is like. So the dashboard on the left-hand side basically tells you, gives you assurance that that current ward is being cleaned effectively. But also what it does is it allows you to go back. So I don't want people going around with clipboards saying, oh, the machine's on, yes and no, because we're running this for a whole year. Basically, we can go back into all the data and say, what was the particulates back then, or what was the CO2 back then, what was the temperature back then. I'd really love to have noise here as well, because that's obviously a big issue when you're putting in these machines, which are essentially sort of big fans sucking through filters. No guesses for saying what happened on Thursday. So this was actually our switching on of our second intervention ward. So as you can see on Thursday, the particulates start to drop and we get a really low level. I'll show you the next some of the data on how low we can get things. But we're able to see an effect in real time, which for the study is important. You might not need this in all your hospitals, but it is useful to know at least if the machines are switched on, because there's no point paying for them and then them just sitting there. I stole this from, you might have seen this earlier, from Dr. Peters, but positive pressure room, but smoke's going in. So an unexpected discovery was that we could use these sensors actually to detect where the air's going, and is the air going where we thought it should go. So the next slide. Maybe I'm not pressing hard enough. Oh, there we go. So this is my ward. These are all the multi-occupancy bays. piddly amounts of side rooms and a bathroom that used to be a side room. And we've got 2 zones because halfway through COVID, we realised that if you cohort COVID patients on a ward, you lose whole ward while you're changing over the ward. So they put doors in between with nice gaps in that allow air through, but so that we can have red patients next to green patients. But essentially we zoned them and said that this green area is the zone that we're going to sort of look out at. And then I think we'd had the sensors in for a couple of weeks, and I got a call from Darren, who designed the sensors, and said, can you find out what happened at 4 o'clock in the morning? Because it looks like the sensor fell off the wall. So I went onto the ward and had a chat with the ward manager on the ward. And just to highlight, so what you want to think about is sensor 1 is in the patient bay, sensor 2 is in the corridor right next to the bay, and sensor 3 is halfway down the ward. So what we actually found was this signal was repeated in all of those 3 sensors. And when I asked, it was actually a patient had fallen out of the bed. Not only, patients don't just fall out of bed, they fall spectacularly. So this lady had fallen, and in her attempt to stop her falling, had grabbed onto those piddly blue curtains and brought down all of the ceiling track, half the ceiling tiles, and still ended up on the floor. Interestingly, that's the first bit, the first spike. And then what happened is lots of staff eventually realised that someone's on the floor and then rush in. So 4 staff had to get a big piece of equipment, a full hoist, and hoist her back into bed. Luckily, no injury. But that spike in particulates at sensor 1, which was actually in her bay, directly opposite her bay, so it's getting the full force of those environmental aerosols. These are not necessarily infectious aerosols, but they're dust, they're lint from clothes and things. They're in the sub-micron range, so they're the small floaty ones. It was then detected at sensor 2, which is just outside in the corridor. And then it was detected in sensor 3. And then we have one of our engineering professors, Professor Clive Beggs, is really good at looking at time series data and showed that that is correlated. So, I mean, you could see it on the previous slide, that there wasn't anything happening, and then something happens, and then nothing happens. And we saw that with each of these sensors. So it was almost like ripples from a pond. You drop a stone, and then these aerosols are being migrated out. But that's all good, because that's how the airflow is designed in a hospital. The air goes into the bay, and then it goes into the corridor. Good, it's away from patients. That's perfect. And then it sort of travelled further down the ward. So that's also perfect, although it did go through the doors. Luckily, when we do open this ward as red, we start with the red ones in here. So by the time this bay is then full with COVID patients, the green is already filled. So that's not going to be too much of a problem, unless you get 2 strains, I suppose. But then we thought, actually, so we're seeing all these little particulates going around. We asked Professor Beggs, well, can we actually introduce something? Now, bearing in mind this ward is like your wards, you will never ever be able to empty a ward to do an experiment. You're running at 99% capacity all the time. So how do we introduce an air, like a contaminant into the air without sort of filling it with smoke? And that might worry people, although the toaster's usually going off. So what we did is these stars are just saline nebulizers. You've got them on every single hospital ward usually. And we just kept topping it up with saline and just let the saline nebulizers off till we reached a plateau phase and then looked at where they went. Now the purple is where we were hoping the air would be going, such that actually we only ever see the signal at sensor D, and we don't see the signal at either A, B or C. Because if we see the signal in A, B or C, there's not enough air coming out of the bay in order to stop that contaminant going from one bay into the other. So that's what we hoped, as you can probably guess, but that's not what we saw. So what we saw is when we actually let off the nebulizers, you get a spike here at sensor D, which is here, and then about 3 minutes later, well exactly 3 minutes later, 180 seconds, you get the same spike. And you can't say that is not the same as that. Bearing in mind, these sensors don't talk to each other, they just report to a central unit. So that is mirroring. And what's equally unfortunate is that it's mirroring it in exactly the same quantity. So there's very, very little flushing out from this bay happening here to dilute the dilution and pollution. There's very little dilution going on. In fact, all of this aerosol was going the sort of the wrong way. Now then, if you put the two together, we've got those aerosols coming from the patient that fell. It could be COVID. She could have had COVID. It's coming down the corridor, coming out of the bay where we thought the ventilation was working, but then going into this bay. And then you're starting to, putting the two together, thinking back to the transmission network slide. Why did patient in bay 1 infect patient in bay 3? Well, you can see exactly. The other thing is these things are travelling huge distances. So they're not going just and stopping at 2 meters. The whole distance is down to 10 meters, just here to here. So if you think we've got a distance 20 meters away, big problem. So then what we thought is, finally onto the HEPA slide, you'd be wondering why it's taken so long to get to the HEPAs. What actually happens if you fill the air with a contaminant and then turn your HEPA on? And this is not on at the highest level. This is just on at the level that we were going to run it at, so sub sort of 40 decibels. So the blue is when we fill the air with aerosol, we turn the nebulizer off, and then we either turn or don't turn on the HEPA. And the blue is what happens with the HEPA turned on, and you can see a massive sort of decrease really early on, and a very slow, gradual decay curve with just the background ventilation. Looking back, this ward, when we've audited it, has around 2 ACH, so nowhere near the 6 that you require. The other thing to sort of point out is that the level at which you then achieve having sort of some form of filtration is much lower than your baseline with the standard ventilation. And so you can either equate that to a nurse going into a patient's room can spend an hour and 15 to get infected as opposed to 15 minutes, or equally 5 times seeing that same patient. So you can see actually if you extended this even more to beyond a shift, then you're talking about lots of staff and also patients that are not then getting secondary infections. So from our results, we basically concluded, well, obviously we knew this from people's work before, but they definitely go beyond 2 meters, and we've proven that on our wards. They also, and this is where you can never take sort of anything for granted. They can go against the airflows that you think are going, and that sort of reiterated, if you think something's positive pressure, actually show that it's positive pressure. Or have a system that's alarmed such that if something happens and the ventilation fails, you know that it's failed. You don't have to wait for someone to get an infection it to spread before you look into it. We know now, obviously, the work that you saw in Dr. Peters' work earlier, that they significantly reduce infectious aerosols. We've shown that at Addenbrooke's. But in this ward in particular, and in the other intervention ward, we made the decision that actually we needed to put the intervention in the bays as well as in the corridors, because not all the infected air is going into the corridor for you then to filter. Some of it is leaking back. And so in our study, well, I'll show you in a bit. In our study, we've got 6 machines on each ward. So it's not a small number of units. If you're interested, we've got a poster that I realised it's actually a tablecloth. It's on the air purity stand. It was meant to be put up. I will be having words later. But if anyone's going to the, when is it, the 20th of May, I've forgotten what date it is now, the HIS conference, which is coming up, this will be presented at the HIS conference. And then just to talk a bit about what we're going to do, or what we are doing now. So the first intervention ward went live in September the 29th last year. The second intervention ward went live at the end of February. The reason we're doing a staggered intervention is because, well, for 2 reasons. Firstly, if something happened historically, like a new variant that happened in September, that all of a sudden you're getting more transmission, we're able to correct for that because we can see that it didn't happen on the second intervention ward. But also a risk for our study was always going to be that Addenbrooke's really go hell for leather in for HEPA, which they have done. So we are struggling at the moment to find a ward that doesn't have HEPA on it. Because the route that Addenbrooke's have taken is if you identify a problem ward, you then install HEPA, and problem ward is outbreak ward. So if you have an outbreak, HEPA goes in. And then, so what we're finding is obviously most wards have had outbreaks on, most wards have HEPA, and so we haven't naturally got a comparison. We still do have a control ward for now, touching wood. So hopefully there's going to be no orthogeriatric patients that get COVID Otherwise, that will also get HEPA as well. We're not just interested in COVID, though. If you look at all the bugs that we're sort of looking at, parainfluenza, picornavirus, all the respiratory viruses, but then obviously aerial dissemination is another key thing we're looking at. So the whole reason that we do sort of disinfection, get the patients out, disinfect the ward, is because all those non-contact surfaces are also becoming contaminated. So we're looking at MRSA, C. diff. I think the real clincher, because obviously I've got to persuade people with money to pay for this, is going to be length of stay and bed days lost. Because if we can show that, that we actually improve that, then I think we're onto a winner. And the other thing just to say is that I'm also a human person, a human factors person, so I'm really interested in looking at how the staff and the patients find the units. And interestingly, we put the units in as sort of a sham intervention where we put them in but didn't turn them on. And I went round and asked 10 patients and staff how noisy or how drafty they were, and 50% they were very noisy and very drafty. This is what the study is. This is it. This is the study. So the big sort of blue are the tall Aerotitan 3000. I don't think Darren's brought those, but the smaller ones in the bays, the two-tier units, are the Aerotitan 2000s. And then scattered through the ward, we've got all of those little boxes, those sensors looking at the environment. And then we're doing surface swabbing, and then we're also doing air sampling. So we're looking at what bacteria, what viruses, what fungi we get, what AMR genes we get over the course of the whole year, weekly. And we're using Steve Baker's lab, where he's got a fluidigm system. So we can look for 86 pathogens in 86 samples for quite low cost. So we're looking at sort of environmental contamination, and hopefully we can show that cleaning the air also has a secondary effect on other things like surfaces. And just to say, this is my penultimate slide. All of these beds are filled with patients, and it's been really hard to be a geriatrician and to not really be able to do anything for your patients when COVID comes in and it takes out sort of a third of the ward. And when we were at sort of the first wave and 50% sort of death rate, 30% death rate, it's been quite hard. So hence, my reason for going into this. So to answer the question of why is a geriatrician talking about HEPA filters, that was basically my motivation. And it's sort of also the motivation for my team. We're lucky to have Dr. Peters as our microbiology lead. Once again, direct all micro questions to Dr. Peters. But we've managed to accrue a real sort of not just Cambridge-centric, but also we've got Glasgow with Chris Illingworth. You didn't pinch him completely. He's still going to do our modelling work to look at sort of viral transmission. And the other key thing I would say on this is that you will never get anywhere if you don't have your estates people on board. So Andy Turner is our estates guy that basically looks after all of the units in Addenbrooke's, which is a mammoth task. And if he didn't sort of put me in touch with a research company in order to do this study, we wouldn't be here today. And I think that's it.